Good morning, everyone, and welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is Reading the Tea Leaves, What's Up Next in Healthcare Regulation? You may submit questions during the webinar by typing a message into the question pane of the control panel. Also, immediately following the end of the webinar, you will be asked to complete a short survey and to submit any questions. We will respond to questions posed during or after the webinar by email. We've posted in the handout pane of the control panel a PDF copy of the slides for your reference. Also, you will receive an email later today with a copy of these slides and a recording of this webinar. With that, I would like to introduce our presenters, Martie Ross and Kathy Reep.
Thank you, Laura. Good morning, everyone. For those of you who have previously attended our Healthcare Regulatory Roundup webinars, you know that Kathy and I are very fond of top 10 lists. And as we were discussing a topic for this webinar, we thought the title, Things that Kathy and Martie find interesting, would not necessarily be appealing to our audience. And so we came up with Reading the Tea Leaves. But really our intention for the next hour is to highlight for you some very recent developments in the healthcare space, which we think will have long-term implications, certainly rise to your to-do list in relatively short order. And it's just a shot in the dark as to what we've included on this list and what we've excluded. For example, yesterday, the Office of the National Coordinator, ONC, published its latest proposed rule, which refers to as HTI-1, which includes the implementation of the EHR reporting program, modifications to the information blocking regulations, and the revisions to the HIT certification program. Certainly that alone would merit its own hour-long webinar, but it didn't make the list today because they published it yesterday. But we are going to cover some sort of high-level policy activity that's going on, as well as the published federal fiscal year 2024 proposed rules that have been released in the last week. And then just some more limited developments that we think are interesting. And hopefully we will close out with the discussion of HIPAA, which of course now highlights the published this morning changes to the HIPAA privacy rule with regard to reproductive health. So never a dull moment in the space of healthcare regulation. Next slide, Kathy. I always like talking about the trustees report. This is the 58th annual, yes, Medicare and I are the same age, but the 58th annual Board of Trustees report regarding the status of the Medicare program, released on March 31. And it's just a great time to get some perspective on the size and scope of the Medicare program and the rough road ahead for this program. So in 2022, Medicare covered 65 million Americans. It included expenditures of $905 billion, which calculates to about $14,000 per person. Medicare is actually a collection of programs under one heading. The first part is Part A, which is funded by the Hospital Insurance Trust Fund. So when you pay your Medicare payroll tax, that is what is funding the Hospital Insurance Trust Fund. This pays for hospital inpatient services, skilled nursing, hospice, home health. That total expenditures in 2022 is just shy of $400 billion. Was just shy of $350 billion. The actual income to the trust fund was just shy of $400 billion. That bogey between the two is the balance in the trust fund that is, its purpose is to cover increasing costs over time. Part B of the Medicare program, which is primarily outpatient services, and then Part D, which is prescription drug coverage, those are funded through the Supplemental Medicare Insurance Trust Fund. This is a combination of general revenues, so it's mandatory non-discretionary spending funded through general revenues, general tax dollars, and then also beneficiary premium. So in 2022, $330 billion came out of general revenue to fund the SMI. And then premiums from beneficiaries totaled 131 billion. That's higher percentage because typically that runs about 25% funded by beneficiary premiums, 75% by general fund. It's up to getting closer to 30% because of congressional action several years ago that increased premiums based on income for individuals. Part C then is the Medicare Advantage program, which is CMS paying dollars to private insurance companies to sponsor MA plans that provide them benefits for those enrolled Medicare beneficiaries. Part C is funded by allocations from both the HI Trust Fund and then the SMI Trust Fund. About 170 billion comes out of HI to fund Part C. About $234 billion came out of the SMI fund, i.e. general fund plus premiums, to fund MA payments, which comprised about 44.5% of all Medicare spending in 2022. Interestingly, the trust fund always reports on the administrative expense associated with the program, which this year came in at $11 billion, just 1.2% of all spending on Medicare. So it is a relatively efficient program for all the things and cuts it takes, but we provide a heck of a lot of health care to 65 million people with an administrative expense of 1.2%. Next slide. The top line every year in the Medicare trustee report is when does the HI trust fund go broke? When do we reach the point where the dollars coming in to the trust fund are less than the dollars going out? And this year the announcement is 2031 is when we effectively go broke in the trust fund. What that really means is the projected costs to provide Part A coverage will exceed the projected revenue from the payroll tax. In 2031, it is anticipated that there will only be funds available to pay 89% of incurred program costs. So there's a gap and some methodology for filling it. The good news was that this year represented 1 year of eligibility for me before the program goes broke, but in fact 3 years later and have been reported in the 22 Medicare trustee report. And thus things are looking up, and we'll talk about some of the reasons they're looking up here in a second. The SMI trust fund, Part B, Part D, never goes broke because of the way it's funded. Is every time we just need more money out of general revenue to meet the obligations of Part B and Part D, we just pull it out. So there's never any issue with the trust fund itself, but of course there is the issue that we're just spending a lot of general revenue dollars on the Medicare program and those obligations going forward. And then you see here the money quote from the trustees that, yes, the program's going broke. The sooner that we actually address this, the better, because it's going to require significant changes in behaviors by providers as well as payers. Next slide. So how do you feel? Next one more, Kathy.
Whoops. Okay, what'd I do?
It's not a webinar unless we have slide issues, right?
There we go.
Party till something is broken, not a webinar until the slides don't work. Okay, what are the options? What's on the table to address this fact that we're spending more on Medicare than we are bringing in the door? I mean, obviously, number one is raise taxes. We have been sort of at the same percentages of payroll taxes for a long period of time. You know that you pay 1.45 of your payroll, the dollars you receive in payroll go to Medicare, 1.45 matching from your employer. If you're a high wage individual earning more than $200,000 a year, your income above $200,000 is then taxed at an additional 0.9% going forward. That's been pretty steady. That's one option, certainly, is raising the payroll tax. And remember, Part A doesn't have to be funded just by payroll taxes. And there's no prohibition that Congress can't step in and raise taxes some other way to shore up the Part A trust fund, or again, to meet the general revenue obligations for Part B. Another option is to shift more costs to beneficiaries. You can accomplish that by reducing or restricting coverage, saying we're just not going to pay for that anymore, or we're only going to pay for those services in limited circumstances. We can always increase the percentage of Part B that's funded by premiums. Again, it's been climbing up from that previous 25% up closer to 30%, but we could take that even more aggressive and raise those premiums even higher and then generate more revenue to offset the general revenue contribution. We can also increase beneficiaries' co-insurance obligations. Currently, across the Part A and Part B program, there's a 20% co-insurance responsibility for beneficiaries, with the exception, of course, of preventative services. We could raise that percentage, say to 25, 30, or higher percentage, similar strategies that employee health plans have pursued. That's another option. Third option on the table is to cut provider reimbursement. And that has been, of course, a strategy that has been pursued aggressively through recent years. Most recently, in the Inflation Reduction Act, we had the introduction of drug price negotiations in the Medicare program, which has some pretty significant dollar impacts longer term. It's one of the reasons, in fact, that the trustees extended the life of the trust fund by 3 years this year. And we'll see some changes there. The other option, of course, is moving more services out of hospital inpatient Part A into outpatient services. Again, that's the second reason that the trustees cited this year for extending the program by 3 years. We could see even more of that coming forward. But keep in mind,
that would also then impact patient liability because of the per claim out-of-pocket costs.
Exactly. But keep in mind when you talk about cutting provider reimbursement that we are already facing the additional 4% sequestration starting in 2025. We kicked that can down the road in the Consolidated Appropriations Act of 2023, but the law still says we have to pay for the fiscal note on the Inflation Reduction Act, and that will result in a 4% additional sequestration. So 2% already in place, going to add 4% to it. So we're talking a 6% off the top haircut starting in 2025. So that's already in the works, and that doesn't extend or impact the life of the trust fund. We can try to reduce demand for services. We can accomplish that by reducing the number of eligible beneficiaries. Excuse my morbid comment here, but that's the third reason that the trustees extended the life of the trust fund by 3 years, because lots of really sick people that cost a lot of money died during COVID. They say it a little more gently than that, but it's sort of the culling the herd effect. Terrible comment, but that's the reality of it, is that a lot of high cost patients no longer are expending Medicare dollars. I don't think that's necessarily a strategy we want to pursue going forward, but we certainly have to appreciate the impact that has had and cannot intend or expect or rely on similar reductions in the future. The good, happy side of this is really focusing on managing beneficiaries' health. We know that there's an incredible amount of avoidable cost in our Medicare program. We could spend more on front-end preventative services that prevent the higher cost expenditures down the road. That's why we talk about population health strategies and the like, but that is one critical way of controlling healthcare costs. We can reduce payments to MA plans. Again, they can become less than 44.5% of our Medicare spend. Well, if the rate announcement published at the end of March is any indication, we don't really have the fortitude to accomplish that. There had been a proposed 1% increase in MA payments for 2024. What we ended up with was over a 3% increase in MA plans. That is certainly proving to be a powerful lobby when it comes to protecting those payments. We can reduce administrative costs, right? But it's always the solution is let's just make it cheaper. But as I said, it's already only 1.2% of total spend, so not really much of an opportunity there. And of course, there's the opportunity to eliminate fraud, waste, and abuse from the program. Both in 2021 and 2022, OIG reported about $4 billion in savings as a result of their efforts to combat fraud, waste, and abuse. But of course, that's only less than half of 1% of total spend. So I don't think we're going to enforce our way out of these challenges as well. So that's really encouraging news, isn't it? That we've got a significant shortcoming in our Medicare program, a continual drain on general revenues, and really no palpable solutions on how we're going to figure this out, but encouragement from the trustees saying the sooner you work on this, the better. The sooner we can culturally adjust changes in the program, the better. We'll see where that goes. So on that positive note, Kathy, over to you to talk about the president's budget.
sure, let's take a look at what the president has proposed to do. Obviously, we've got a long way to go to get an actual budget through Congress because nobody's talking to anyone else. President and the speaker are both have their views and not a lot of coming together to talk about options.
And there's a debt ceiling debate in here as well.
Yes.
On top of all of that.
And if we hit that debt ceiling, what happens, Marty?
Well, we don't pay providers. How's that?
That's right. So, you know, you need to be hoping that they start talking to each other quickly. But meanwhile, go ahead.
Just one more comment on the debt ceiling. I should have made this comment earlier. The beauty of the debt ceiling is it really doesn't impact the HI fund. It sure the heck impacts the SMI fund. So it's Part B payments that are at risk in the debt ceiling debate. Because again, it's an entitlement program. Those dollars have to be spent. And when we're talking about trying to manage the debt ceiling by cutting federal deficits, what you're cutting is the Medicare program.
But the issue is also if we shut down, then CMS isn't operating and therefore the MACs are not paying your claims and reviewing your claims. So that does impact the Part A side.
Yes.
So everybody just keep pushing for something for us to get a budget, to get resolution, et cetera. And it's one of those things that we keep pushing it down the road and we'll take care of it later. It's later. We've got to resolve this. But when the president submitted his budget, proposed budget, his request for Health and Human Services was $1.7 trillion. But included in his budget were some options. And remember, this came out in February, so this was before the trustees report came out with the projected end date for the trust fund. But he did include some provisions that were intended to extend the solvency of the Part A trust fund. One provision that he included, and it goes back to what Martie had shared about what are the options for adding years to the life of the trust fund, but that was to increase the income tax provision on incomes above $400,000. Again, everybody is currently paying 3.8% between the employer and the employee. Well, they would increase it by 1.2% to a total of 5% for those individuals with incomes greater than $400,000. That is an area that has been talked about in the past. We've had discussions of increasing that, and it's always been an option that has been included in the trustees report, but now we're looking at something included in the president's budget. There was also provisions related to expanding prescription drug price negotiations. We know that we had the Inflation Reduction Act that gave us the option, you know, certain drugs that we were going to negotiate rates on. This would be, if adopted through the president's budget, if Congress were to put this in place, then they would expand those drugs that we would be negotiating prices on. The increased premium tax credits that were extended through 2025 by the Inflation Reduction Act, those would go into be made permanent. Again, these are proposals. This is not legislation or regulation. And typo here, it should be Medicaid-like coverage, okay? But it's a provision for those states who have not expanded Medicaid to actually have a federal program put in place that would provide Medicaid-like coverage for those individuals who would have been eligible under Medicaid expansion, but currently do not have coverage.
Yeah, Kathy, it's interesting because like in the States, and raise your hand proudly, right? Kansas and Florida are two of them. It is, you think, well, this isn't fair, right? Because why are these states getting off of it? Remember, the expansion population is covered 90% by federal dollars. So what this solution is to effectively kick the can by paying that additional 10% for these populations in those states. So it's not as a large financial hit as you would anticipate.
But it is something that I personally think there could be some states who would balk at this coming into play. Whoops, here we go. This is too sensitive today. There would be a requirement, and we've seen this, that some states are putting this into place, but there would be a requirement on all states to provide continuous Medicaid coverage for 12 months postpartum. So this is a provision that, again, a number of states have adopted, but they would be requiring all states to expand this moving forward.
I think we're up to 30, so it's going fast. But
right, so it's not that many more states that would be required to do this. A lot of focus on in the budget related to expanding access for behavioral health. And some provisions that are in here, I think actually when you think about the Medicare program, and we haven't had a lot of change in terms of coverage on behavioral health since the program was first established, but they are looking at provisions that I think would make access so much better. Just a couple of them that I wanted to touch on. Provide first dollar coverage for 3 behavioral health visits per year. Very important. I mean, it's having to pay that out of pocket if you don't have a supplemental insurance, but paying those first dollars always been an issue. But this would allow 3 visits per year to be paid without cost sharing on the part of the beneficiary. Additional behavioral health professionals would be able to enroll in the Medicare program and be paid under the program, allow them to treat patients and receive reimbursement for that. Huge win on the next one, and that is to eliminate the 190-day lifetime limit on psychiatric hospital services. This is a provision that has been in place not in an inpatient psychiatric unit of an acute care hospital, a distinct part unit, but for freestanding psychiatric hospitals, there has been that 190-day lifetime limit. This is a movement to eliminate that. I think something very important because it really hasn't kept pace with the country today. A Mental Health Parity and Addiction Equity Act would be applied to the Medicare program, and more on equity within mental health issues, requiring insurers to use medical necessity criteria consistent with those that have been developed by a nonprofit medical specialty association. In other words, use the criteria that was established by experts to determine whether or not the services that are being ordered are actually required. And then authorize regulation of behavioral health network adequacy requirements for the Medicare, for the managed care plans. Again, vital that we have that. The $35 cap on copay for insulin would be extended to all Americans, not just Medicare enrollees. Huge issue because think about kids and think about young adults and the current out-of-pocket costs for insulin. And an interesting one, and we'll see how the lobby goes, but it would be to expand the No Surprises Act not only to apply to air ambulance services, but also to ground ambulance services. You might be aware that under the No Surprises Act, the only thing that applied to ground ambulance was the requirement for a task force or a committee to come together, a work group, to discuss how this, how the NSA could be applied to ground ambulance. Well, they've only begun meeting, but now we have in the president's budget proposal to extend the NSA to ground ambulance. I think that would be well received by a lot of consumers. The next topic that I wanted to touch on, 2023 MedPAC reports. As I talk about their payment updates, I want to touch on 2 things related to MedPAC. First of all, MedPAC's role is to advise Congress. They were established under the Balanced Budget Act of 1997 to advise Congress on issues affecting the Medicare program. They are not advising CMS. Okay, it is a report to Congress. This is the March report to Congress that I'm going to talk about in a minute. The letter that was sent from MedPAC on March 15th, or the report that was sent, the letter accompanying it was to the Vice President and to Kevin McCarthy as representing both the Senate and the House. So that is the letter that was sent. Included in the letter was a statement, and I'm one of those who reads the MedPAC transcripts every month. No comment. But every time they talked about a recommended rate, up, increase, decrease, whatever, there were those commissioners who said, what about COVID? What about the costs that hospitals, nursing homes, home health agencies, et cetera, physicians have experienced during the last couple of years with COVID? And they constantly referred to, we think our role is to recommend an increase or a decrease based upon the data that we have that has been reported by providers. It is not to address a one-time situation. That should be done elsewhere under the law, not in the annual updates. In the letter, it says we discussed some of the effects of the pandemic on beneficiaries' access to care and providers' revenues and costs. However, a fuller discussion of the pandemic's effects on beneficiaries, providers is beyond the scope of this report. And they say our statutory charge is to evaluate available data and ensure access to care for beneficiaries. So these recommendations, although they might make you angry, are based upon the information they had to go on, not to take care of an issue that we really don't have good data on yet. So we'll see where it goes in the future. Okay, I really don't know why this is being so sensitive, but the first report in the March report, the first area that was addressed was hospital services. Under the inpatient prospective payment system, they are recommending current law plus 1%. Current law is based upon what is the overall inflation increase in the cost of services. They are saying that increase plus 1%. Again, a lot of folks are not happy with that because of the PHE, but this was their recommendation. We're going to talk in a minute about the proposed increase from CMS. So obviously CMS is going with something that is different than what MedPAC had recommended to Congress. But an issue that has been being discussed over the course of the last year related to the Medicare program and disproportionate share. This is Medicare DISH, not Medicaid DISH. But they want to totally revise the Medicare disproportionate share system and payment for taking care of low-income individuals. They want to create the Medicare Safety Net Index, the MSNI. They want to add significant dollars to the MSNI pool. They would basically be taking the DISH dollars, moving it over to the MSNI pool, increasing the total dollars, distribute that money based upon as add-on payments for both inpatient and outpatient services. Recognize that if you're treating a large volume of low-income inpatients, you are also probably treating a large volume of low-income outpatients. So they want to distribute the dollars based upon both inpatient and outpatient volumes. But before I get to the issue related to Medicare Advantage, but they want this to be low-income Medicare enrollees. They want to take straight Medicaid out of the mix. They would look at dual eligibles, but they would not be looking at straight Medicaid patients, Medicaid patient days. The argument that was addressed in the report and in all of the meetings that MedPAC had essentially said we should not be using Medicare dollars to reinforce the financial status of high Medicaid providers if they are not high Medicare providers. We shouldn't be using the trust fund dollars in that way. We're going to have to find another way to address the high Medicaid hospitals. And they then turned to another organization called MPFS, which is the organization that advises Congress on Medicaid, and said they need to come up with a way to address disproportionate share as it relates to the Medicaid program, but that the Medicare dollars should follow Medicare beneficiaries, not Medicaid enrollees who do not also have Medicare. So it's going to be interesting to see where this one goes. But when we look in light of the trust fund being in jeopardy, how should we be spending this money? They would like to exclude the disproportionate share or the MSNI funds from being paid direct to as a part of the benchmarks to the Medicare Advantage plans, and pay the money directly to the providers who are treating these Medicare Advantage patients. Other recommendations on the physician side, they want to update the base rate for physicians by 50% of the projected increase in the Medicare Economic Index. So this is would be not just limiting them to the MEI, but giving them a bump over that as well. And now let's get back into this whole idea of treating a large volume of low-income patients, because this is the first time I think MedPAC has actually addressed this, but it would be to create a new pool of money. This is not taking money from the current Medicare program and redistributing it, but to take non-budget neutral add-on payment, to create a non-budget neutral add-on payment without cost sharing to increase payment rates to physicians who serve a large volume of low-income patients. There would be a 15% add-on for primary care physicians and a 5% add-on for all other physicians. So if you are treating a dual eligible, the way they have proposed this is if you are treating a dual eligible Medicare, Medicaid enrollee, then you are going to get an increase in your payment rate of 15%. If you're primary care. Marty?
Yeah, this one seems to be getting some legs because
Yep.
We're facing, when the Medicare physician fee schedule was published in July, the proposed rule, and we're facing a 2%, additional 2% cut, just based on the prior year legislation.
Exactly.
And so I think there's a serious conversation going, okay, whatever we did with MIPS and MACRA didn't seem to work in terms of stabilizing physician payments, probably because of COVID, but we won't go there, MedPAC, I promise. But there's already legislation that's been introduced in Congress that very closely follows this recommendation. I am never one to predict what legislation is going to go anywhere. It always becomes a game of what gets included in this year's Consolidated Appropriations Act. But I think there's some movement here, and one in which I think we really need to be engaging with our elected leaders to find a solution, because we just can't take another 2% cut across the board for physician practices. And it's going to have to be a solution like this that makes some difference. It may not be a 2% across the board increase, but at least some strategic spending to address sort of these health equity issues that CMS is so committed to addressing, administration across the board is committed to highlighting.
And the one thing in here is, as they kept having their discussions, and they did propose to do this without cost sharing, that is also going to address the fact that the increased dollars are going to come from the Medicare program to the physicians. There isn't going to be an impact on the individual other than perhaps actually having better access, but no cost sharing as it relates there. Also included in the March report, now we get into reductions in reimbursement. For rehab and for skilled nursing, they have recommended a reduction in the base rates by 3%. Again, we're going to talk about the proposed rules, and CMS didn't get the letter because they're proposing increases. Home health, and we won't have a proposed home health rule until around July. But home health, they are actually proposing to reduce the base rate by 7% because they look at the profitability of home health agencies, and they are coming up with 7%. But they have recognized that there are additional cuts on top of that 7% that are already scheduled to occur for home health agencies. When we implemented the new payment methodology for home health, it was to have been done in a budget neutral manner. If you don't remember, this was when we went down to a 30-day episode. And there have been two overages, I guess I would say, that have been identified by CMS that need to be addressed by 2026. The money needs to be recouped by 2026. The first is a $2 billion overage that was identified for the 2020-2021 years as we transition to the new program. And then there was an additional adjustment that was required in 2020. Well, it was supposed to all be done in 2023, in excess of 7% reduction, almost 8% reduction that was to be taken, but they only implemented half of it this year. It was a 3.925% decrease in home health spending. There is another 3.925 that is supposed to happen in 2024. It has to happen before 2026 unless the law changes. So it will be interesting to see what the proposed rule related to home health comes out to say, because it could have a huge impact on access if they wind up with a significant reduction in the rate, as well as recoupment of overpaid dollars for the program not being budget neutral.
Hey, and overlay that on the impact at the end of the PHE, because as we go back to the mandatory 3-day hospital stay to qualify for a SNF stay, for those folks that have been going to SNFs, most likely are going to end up in home health. So we're going to probably see an increased volume of home health. We certainly saw that decrease with the 3-day rule being waived during the PHE. So it'll be very interesting to see what happens with demand in addition to these payment changes. It's going to be an interesting time for the home.
Well, and staffing issues, because we've been able with home health not to have all the RN evaluations of the care being given by aides, et cetera. So now we're going to get back into that. So do we have enough RNs to do that? Going to be concerning in terms of the impact overall on access to home health. There is another report that is, okay, there we go, that is, we expect from MedPAC, that is their June report to Congress, where the March report always addresses payment adjustments. The March report addresses payment adjustments. The June report is going to be looking at how the system could be changed. Things that they've been discussing, revising the wage index system, looking at site neutral payments, aligning fee-for-service payment rates across ambulatory settings. That has been a major discussion. The high price of drugs under Part B. So those are going to be drugs provided in the hospital outpatient setting or in a physician's office or clinic setting. You might remember that a couple of years ago, MedPAC provided at the request of Congress an outline for a PAC PPS, a post-acute care PPS, that essentially was skilled nursing, home care, inpatient rehab, long-term acute, a single prospective payment system. CMS came back from that proposal with a revised proposal, and now MedPAC has been instructed to report on modifications to what CMS has done and what works, what doesn't work, and that will be a part of the June report. So be interesting to see if we ultimately wind up with a single PAC PPS. They want to address the need for safety net payments for skilled nursing facilities and home health agencies. Remember, I just talked about revising the disproportionate share program for hospitals and applying it to outpatients, creating a disproportionate share of safety net index program for physicians. Well, now they're questioning, do we need this for SNFs and home health agencies? There will be a report on the future of telehealth under Medicare, and Congress has requested a behavioral health report that will be it will be included in the June report, although it was a separate report requested by Congress. So stay tuned. Marty and Kathy will be talking about the June report sometime late June, right? Maybe. All right. Meanwhile, back on the farm, as we're reading those things, we wound up with the proposed rules coming out. So just going through some of the things that we have. First of all, inpatient rehab. The rule was issued on April 3rd, and comments are due June 2nd. They are proposing an increase in the payment rate of 3.7%. And they're also proposing to increase the portion of the payment rate that is tied to labor. So if you have a high wage index over 1, that makes your payment go up. If you have a wage index less than 1, it makes your payment go down. In 23, for this year, they had proposed a 2.8% increase. We wound up with 3.9. So a lot of the reason we wind up with this additional increase is providers commenting and addressing the fact that 3.7 isn't enough. So time to start looking at writing letters, but recognize that they are proposing a significantly higher increase than they proposed last year for inpatient rehab. I think this one's really interesting. It took me by surprise to see this in the proposed rule, but they are proposing to allow inpatient rehab facility units to open, distinct part units to open anytime during your cost reporting year, not to have to open on the first day of the cost reporting period. That's a huge change, because I remember having a unit up and ready to open. We were treating non-Medicare patients. If we treated Medicare patients, we just literally couldn't bill for them. This would be actually allowing your IRF units to open whenever you're ready to open. They are proposing some changes to the IRF quality reporting program. We're going to be talking in more detail about changes to quality reporting related particularly to inpatient, but I wanted to touch on the fact that they are starting to look at measures related to staff vaccinations and your function score from your discharge function score, adding those additional measures. Inpatient psych issued on the 4th of April and comments due on June 5th. Again, proposing a significantly higher increase than they did for 2023, almost up to the increase that we got. So recognize that this is an area of comment. Is the 3.7 enough? They have also proposed here to address the allowance for you to open an inpatient, distinct part inpatient psychiatric unit at any time during your cost reporting period. Again, you're going to have to notify your regional office and your Medicare administrative contractor, but then you open. So a little bit different technique than what was done historically. I think that notification has to be done. They're proposing 30 days in advance of opening. Increased measures related to inpatient psychiatric facility quality reporting, all of which are focused on health equity. And we're going to see this running through a lot of the proposed rules in terms of the focus on health equity. Skilled nursing, again, proposing a significant increase of 3.7%. Last year, they proposed a decrease. They came up with a 2.7% increase, but this year they're actually coming up with a 3.7% increase. So worth commenting on by that comment period of June 5th. Updates both to the SNF quality reporting program and the SNF value-based purchasing program that were included in the proposed rule. And oh golly, you're going to not have to hear me too much longer, but under the inpatient proposed rule that we kept thinking we were going to talk to you about the inpatient proposed rule, but it didn't come out until Monday afternoon. It was issued on April 10th with comments due on June 7th. They are proposing a 2.8% increase. That's low compared to last year because last year they proposed 3.2 and they finalized 4.3. Does this mean that we're going to wind up getting significantly more than the 2.8? I can tell you that the American Hospital Association and others are already making comments and saying 2.8 is nowhere near enough. Do you know what we've gone through for the last few years, et cetera, et cetera. Hopefully we will see a rate increase somewhere close to where we were last year. As expected, there is a decrease in disproportionate share and uncompensated care payments because increased number of enrolled individuals who no longer have are lacking coverage. The quality measures are being revised, and they are looking at changes to the various programs for HAC and for value-based purchasing, hospital-acquired conditions, value-based purchasing. There will be revisions, but no revisions to readmissions reduction. The reason you see the calendar focused on April 26th is on April 26th for our next HRR webinar. We're going to go into detail on this inpatient PPS rule. Martie.
Medicare Advantage rate announcement for 2024 released on March 31st. This is not actually a rule. CMS doesn't do this by rulemaking. It just publishes an advance notice to which it receives comments and then posts the final rate announcement always by the 1st of April. The advance notice had proposed only a 1.1% increase in payment. If you recall, watch the news at all following the announcement of the advance notice, the plans are up in arms, claiming that this was a cut to Medicare beneficiaries. Obviously successful lobbying because they ended up with a 3.32% increase, or to the tune of $13.8 billion. The big controversy this year in the rate announcement was the changes to the HCC risk adjustment model. CMS had intended to full-scale implement a new model for 2024. The significant difference being that rather than basing the HCC model on ICD-9s, it transitioned to ICD-10s, which resulted in a significant expansion in the number of HCCs and a significant reduction in the number of ICD-10s that tagged to specific HCCs. Talk about inside baseball. But there was much complaining from the MA plans claiming this was too dramatic a change. So they were successful in convincing CMS to phase in this change in the risk adjustment model. So for 2024, for example, 1/3 of the risk adjustment will be based on the 2024 model, 2/3 will be based on the 2020 model. Following year, you flip 2/3, 1/3, and then by 2026, you have full implementation of the model. CMS claims that the actuaries have determined that the 2024 model is far better in its predictive value than the current model. My open question here is what happens to Medicare Shared Savings Program? Because the benchmarks that are established for the MSSP are subject to HCC risk adjustments. And if you look at the technical manual specifications from CMS for the MSSP program, it simply refers to the CMS HCC model for MA plans. So what's it going to be, CMS? Are we going to adjust the benchmarks in 2024 based on the 2024 model, or are we going to use some combination of the models going forward? And again, this is a significant impact. There are certain high volume HCCs that have been adjusted as to their scores and weighting. So it could have a pretty significant impact on the ability of an ACO to impact in any way its benchmark because of HCC scoring. So again, it's pretty detailed, but it can have some pretty significant impact. Also of note here, they're not included in the rate announcement, was the regulations published, final rules published earlier this year regarding the RADV program, or the Risk Adjustment Data Validation Final Rule. This is the method by which CMS reviews data from MA plans to validate their HCC scores. Are you improperly reporting a sicker population because you mastered the art of diagnosis coding and HCC reporting, thus rising artificially the risk score. This gives CMS new authority to extrapolate the finding of sample audits. So if we sample audit medical records from an MA plan and determine, no, your HCC score in this population was not 1.1, it was actually 0.9. They can now extrapolate that finding not only on that sample, but across the entire population for that MA plan. So obviously significant impact here in terms of clawback of dollars paid to MA plans based on the risks in their population, but there's a trickle down effect here to the providers because the pressure now to do coding audits and review medical records and ensure that there is in fact documentations of diagnoses that are included in impact HCC scores is going to be significant. So just put that and appreciate that that's something that is probably not that far down the road. Next slide.
Sure.
You can do it.
I know it's me. It's just slow and moving. All right. We did get a final rule April 4th, if I remember correctly, 3rd, 4th, related to Medicare Advantage. And it was from a provider perspective, a great rule. That's what I'm going to have to say. Great rule. We're going to go into more details on April 26th. You see that little calendar there, but let's just go ahead and get happy with Medicare Advantage plans are going to be required to adhere to the 2 midnight rule. They are going to, their ability to apply site restrictions. This is outpatient only, this is inpatient only, things like that. They will not be able to do that under the, outside of the requirements of fee-for-service Medicare. The appropriate clinician is going to be required to be involved in making prior authorization decisions, and that prior authorization has to be valid for the approved treatment plan. If the treatment is going to last 3 months, then the authorization is for 3 months. And at the same time, if you are switching plans, then you should have a 90-day transition period for your authorization to remain in effect. There is a prohibition for the most part on using internal or proprietary criteria in making coverage decisions. There will be a requirement for enhanced network adequacy for behavioral health services. And of course, there has also been this focus on addressing misleading marketing practices. We're going to go into this in even greater detail on April 26th, but some of the issues that have been the biggest setbacks for providers in dealing with Medicare Advantage plans, and well, that's our rule, those will go away. So congratulations, providers, they heard you.
The surveyors are coming back. On March 9, CMS published new interpretive guidelines applicable to hospitals with regard to their quality assurance and performance improvement programs. If you recall, during the PHE, this particular COP has been suppressed. There's still a general requirement to have a QAPI program within your facility, but all of the nitpicky details have been waived for the duration of the PHE. In fact, pre-PHE, in November of 2019, CMS had published an update, a regulatory update to that condition of participation, but it had never published the interpretive guidelines. So we really didn't understand what this meant in terms of implementation. On March 9th, those IGs, the interpretive guidelines finally came out. Just to highlight key provisions, which you should be aware, is certainly the engagement and oversight by the hospital's governing board. That is all over these IGs, the expectation that they are intimately involved in the QAPI program in terms of identifying measures, reviewing data on measures and the like. There's the expectation of evidence of resources spent on your QAPI program. They're going to look at your budget to see what you identify as dollars spent on QAPI activities. Certainly some additional requirements with regard to medical error and adverse reporting systems, the tracking of annual performance improvement projects. Different than programs, projects are very specific initiatives that you pursue on an annual basis. Then your ability to demonstrate sustained measurable improvements on selected quality indicators. So certainly this is worth your time and attention. within your organization. This is going to clearly be a focus of ongoing and reinvigorated survey activity. For our critical access hospital attendees, we are still waiting. You had the QAPI-QAP, say that fast, right? QAPI-QAPs added to the critical access, the QAPI-QAPs, there you go, to your conditions of participation back also in late 2019. We are still waiting for the interpretive guidelines for implementation of those programs. Next up, Kathy. Let's talk court decisions. This isn't necessarily the most interesting court decision, but we'll just highlight this as its potential impact, is the decision in Braidwood Management versus Becerra. This was the opinion that overturned first dollar coverage requirements for commercial health plans. The Affordable Care Act required that commercial health plans provide first covered dollar for certain preventative care services and included those that were identified by the U.S. Preventative Services Task Force as grade A or grade B recommendations. The court held that that is improper delegation of legislative authority to a non-governmental entity and ruled that there could be no such requirement for first dollar coverage for those particular services. So anything identified by the task force as A or B from March of 2010 forward, according to the court, there would no longer be any first dollar requirement of coverage. Now, there are other preventative services that will continue to be covered first dollar, even after this decision, because they're the vaccination requirements, the HRSA approved requirements for women and children's health, those remain because those are federal agencies making those determinations. But here, it was the delegation to the U.S. Preventative Task Force. The federal government is appealing this decision. They will, and there's other obviously congressional solutions that could address, just wholesale adopt these recommendations that are coming out of the task force, but we'll just have to see how this one shakes out. There's been some really great research published very recently on the impact of preventative care services on savings on the high dollar end of complications. So it'll be very interesting to see how this moves forward, what the response from the market will be in terms of continuing first dollar coverage despite any particular legal mandate. Next up. We pay a lot of attention to what's going on in Washington and Baltimore, and we need to be watching more carefully what's going on in our state capitals. In particular, there is if you are not familiar with an organization called the National Academy for State Health Policy, it claims to be a nonpartisan advocacy organization. They draft legislation for state legislatures to address healthcare issues. And this organization is particularly focused on the provider side of the equation and ways in which state legislatures can take action to control healthcare costs by imposing additional requirements or placing limitations on healthcare providers. This includes a number of cost control initiatives around health insurance, including reference-based pricing, particularly implementing those across state employee health plans, i.e. the state will not pay more than X percentage of Medicare for any services provided to state employees under the health plan. There are cost growth benchmark legislation that's been introduced in addition to premium rate reviews that would prohibit any percentage increases above a certain level in an employee health plan in that state without prior review. We are seeing regulations on anti-competitive behavior being pushed in state legislatures, such as the prohibition on non-compete clause, prohibitions on most favored nations clauses, anti-tiering legislation. Again, this is premised on the idea that consolidation in healthcare has created these powerful health systems that are able to negotiate ultra competitive pricing within their contracts, and the need for state law to control that behavior and preventing driving up prices or having anti-competitive provisions in their contracts. Also, a lot of activity around community benefit. The annual loan report came out this week that shows something like 77% of the nonprofit hospitals that they reviewed actually provided less in community benefit than they received in the benefit of not having to pay taxes. The American Hospital Association was all over that yesterday with a very blistering blog post that talked about the shortcomings of the low methodology. But again, the top line media headline is nonprofit hospitals are taking advantage of you by not giving back enough in the community to justify their tax benefits. So expect that to go forward. And then just one of my little favorites, hospital executive compensation. The SEIU union had proposed an initiative in Los Angeles that would limit hospital executive compensation to the rate earned by the US president, which is currently $450,000 by law. The California Hospital Association challenged this initiative, claiming that in fact, the president also has the benefit of, a security detail and housing provided for them and state dinners, and that their consultant actually said that this is worth $1.5 million. And so that the union was aggressively misleading the public as to what the ban would be. The judge said, really? Are you kidding me? And so now we're in the process of actually approving the signatures for that initiative. But this may be something that we see, crawling in more and more. The union has used this as a way to bring attention to low wage workers in healthcare. I think you're going to see other types of initiatives going forward. And they do not appreciate this is not all going on in Washington. And we need to be very attentive and very attuned to what's going on in our legislators. Because as we learned, Kathy, just last week, you can have to turn on a dime with some of these legislative actions. Next up.
Yeah, just a couple of additional slides. I know we're getting close on time or past time. I wanted to share with you where we are on compliance from a price transparency perspective. The number of hospitals that are in compliance that have posted a machine readable file, doesn't mean it's perfect, has significantly increased since the beginning of the requirement of this in 2021. So we applaud you on that. However, want to recognize that CMS has sent about 500 warning letters out to hospitals related to non-compliance, and that those will then be followed up with, if you aren't compliant, then the request for corrective action plan, etc. CMS has also held a number of listening sessions related to, for consumers, related to the display of the information on the websites of providers. And the major issue that they keep coming up with is we need to find a way to maybe make this more standardized or consistent across providers. That kind of scares me because they supposedly did that with payers, and we'll talk about payer data in a second. But they did come out in November of 2022 with an optional template that you could use for your machine readable file that actually gave you something to work with. Again, it's not required. They have also asked about what can we do to streamline enforcement efforts. Should we expedite the timeframes for compliance following the corrective action plan? What do we do? Can we become more aggressive against hospitals that have totally failed to post information? There has been legislation across the country related to non-compliance, state legislation related to non-compliance with federal legislation. You've got the slides. Recognize that in Texas, we're looking at a penalty under state law for non-compliance, a financial penalty. Colorado, we are actually we have legislation that was effective late last year and in February for critical access hospitals that essentially, if you are non-compliant with the federal requirements for price transparency, you can't use debt collectors or send accounts to collections. And if you do, you can wind up having to pay the amount of the debt plus attorney's fees and costs. So recognize we've got this. Matter of fact, last week there was actually a legislative hearing in Montana related to potential legislation about non-compliance with federal compliance requirements. We've had this discussion about where's the payer data? Why can't we see the payer data? Let's start playing with it. I want you to take a look at this slide. This slide was actually developed by Clarify. The payer data that is out there, it's this area of the slide I want to talk about. United Healthcare alone has more data that has been posted related to payment rates than Netflix, Wikipedia, and the Library of Congress combined. That's a lot of data. And trying to download that, I think my understanding is just to store the data, not to download it, but to merely store it, is about $1 million a year. So it's going to wind up being very expensive to actually start looking at this. And I mentioned this is Humana. This is United Healthcare at about a third of what Humana's data is. So a lot of information that is out there. And Marty?
Let's wrap it up with HIPAA. You might as well forget what's on the slide because of what happened this morning. What we had intended to talk about was there are changes to the HIPAA privacy rule coming. There were 2 proposed rules. We are still waiting for OCR to take action on finalizing those rules. There is nothing at OMB waiting. But this morning, OCR published its new changes to the HIPAA privacy rule regarding reproductive rights. The intent here is to lock down the release of protected health information regarding the relating to reproductive health care that's lawful under the circumstances in which it is provided. Had to read the regulatory language there, but it creates those protections on uses and disclosures. It creates an attestation process whereby a requester of that health information would have to attest that they are not intending to use that data for purposes of criminal, civil, or administrative investigative proceedings against, again, involving reproductive health. So certainly merits your attention, this new proposed HIPAA privacy rule. We will hit the 60-day comment period when this is published, so sometimes in June. But we then expect they'll roll all of this in to sometimes probably the summer or fall, sort of a master HIPAA final rule. So as you're doing your budget, you may want to include additional dollars for HIPAA training going forward. Last slide, please, Ms. Kathy. It's
Yes.
What's coming up next. Kathy's previously referenced that on April 26th, 2 weeks from today, we will be addressing the inpatient proposed rule as well as the Medicare Advantage final
And
rule.
it is the fiscal year 2024 proposed rule, not 2023, because
Okay.
that would be rather boring.
That would be boring because they already know the final rule, but that will be the 2024 rule. And then on May 10, we're back to the No Surprises Act. There have been enough changes going forward. It's time we think we revisit that and address some of the more controversial issues, particularly around enforcement. So we hope we will be able to join you. As always, we will try to keep it within 1 hour, but we apologize for running over today. We just get too excited about this stuff, don't we, Kathy?
It's either that or shopping.
Okay, see you next time.
Take care.
Thank you. And thanks to our presenters, Martie Ross and Kathy Reep. Later today, you will receive an email with their contact information and a recording of the webinar. Also, the slides and recording for every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Also, please remember to stay on the line once the webinar disconnects to complete a short survey and post any questions you may have. On behalf of PYA, thank you for joining us and have a great rest of your day.